Bismillah ar-Rahman ar-Rahim. Welcome fourth year EMP students. This is my third recorded lecture prepared and presented by me, Dr. Khalid Diab, an OB-GYN professor at Ain Shams University. I will share with you the following slides that will review basic clinical management of labor induction, labor augmentation, and pre-induction cervical ripening. By the end of this presentation, the students should clearly understand the following ILOs. The presentation will follow through the following heading titles: an overview on terminology and method of labor induction, labor augmentation, and pre-induction cervical ripening, the indication, the contraindication, and the outcome or complication. It will cover the prerequisite and labor management for cases of labor induction and labor augmentation. The basics of labor were given in previous lectures and should be revised by the student. Induction of labor or labor induction is an intervention designed to artificially initiate uterine contraction with the aim to achieve vaginal delivery before it starts. Labor augmentation, on the other hand, is an intervention to enhance uterine contraction after labor uterine contraction has been already started with the intention to achieve vaginal delivery. The indication of either will follow. Cervical ripening is a process of induction of labor that results in softening, effacement, and dilatation of the cervix, making it ripe, so that later process of induction of labor will be more successful. Induced labors represents 10 to 20% of all deliveries related to the hospital practice. The following are the main list of methods used for induction of labor. Details will be given later in this presentation. As for procedures indication, labor augmentation is indicated to correct uterine dysfunction during labor to increase progress of a spontaneous labor. While cervical ripening methods are interventions used to improve cervical condition to facilitate dilatation once labor is established and increase the chance of vaginal delivery. As for induction of labor, it is indicated when the potential benefits of termination of pregnancy outweigh the possible risks of continuing pregnancy for various maternal, medical, or obstetric, maternal, and fetal indications. Common indications are past dates, intrauterine fetal death, pre-labor rupture of membranes, antepartum hemorrhage, hypertensive disorders with pregnancy. Elective or social indication with no clear maternal or fetal indication should be avoided, especially before 39 weeks due to increased maternal, fetal, and neonatal risks. The following table shows absolute and relative contraindications or cautions for induction of labor. Absolute contraindications are mainly those that contraindicate vaginal delivery, while relative contraindications are conditions whereby caution should be taken due to increased risk of complication, and this may be related to a specific method used. The parturient should be properly counseled for the pros and cons of induction of labor. Her refusal is considered a relative contraindication. When comparing different protocols for induction of labor, outcome measures include: first is success rate percentage, with an overall induction of labor 60 to 80% will achieve a spontaneous vaginal delivery, while about 10 to 20% will have an assisted vaginal delivery and 10 to 20% will have a cesarean section. Failed induction should only be diagnosed in the active phase with the cervical dilatation more than 6 centimeters and after 12 hours of rupture of membranes. Second measure is induction delivery interval. Successful vaginal delivery is usually achieved within 12 to 24 hours. If prolonged, it will lead to mother dissatisfactions and, of course, increase maternal, fetal, and neonatal risks and complications. Of course, the cost of the method used should always be considered. As regards risks and complications for labor induction, it may be related to the procedure, to the induction method, and to the indication whereby labor is induced. Overall, prolonged labor more than 24 hours will require more epidural anesthesia, more increased operative vaginal delivery, and more cesarean section rate. Furthermore, prolonged labor will increase maternal dissatisfaction and maternal infection. Method-related risks include cord prolapse with ARM. Special precautions should be taken when rupture of membranes with a high presenting part. Also, with oxytocin use, maternal water intoxication is a rare complication. It should be noted that delivery of a preterm infant may be the results of an induction of labor with an inaccurate gestational age assessment. Uterine risks for labor induction include uterine overactivity with or without fetal distress, already discussed with labor management, and uterine dystocia. For fetal assessment, this slide demonstrates how intrapartum fetal distress is suspected and diagnosed. And the following 3 slides will demonstrate CTG finding and interpretation and possible management. This topic is already discussed with management of labor, yet verification of understanding is essential and will be clear in the face-to-face session. The following table shows CTG basic classification and their possible line of management. Newer and more complicated classification is currently available. The student is encouraged to understand the basic criteria and management. The following 2 slides will present the latest classification. Discussion for the outline will be carried out in the face-to-face session. The following slide describes the latest CTG trace features. The following slide shows management based on interpretation of the latest CTG traces. Prediction of successful outcome is important during counseling for induction of labor. Predictors of success include maternal characteristic and fetal gestational age. Yet the main predictor is pelvic examination and calculation of Bishop score, originally reported in the 60s, items with score 0 to 3 with several modifications. Modified Bishop score replace percentage effacement with cervical effacement in centimeter. Scores less than 3 is considered unfavorable, while scores more than 9 is favorable. Note to add +1 for previous vaginal delivery and -1 for nulliparity. Unsuccessful induction of labor is anticipated in nulliparous, past date, oversized baby, and low Apgar score. The following slide shows prerequisite for labor induction. Of course, all induced labors should have a continuous intrapartum electronic fetal monitoring during the active phase. The frequency of fetal monitoring during cervical ripening is related to parturient characteristic, method used, and to the indication for induction. All induction are carried out in hospital. The possibility of having cervical ripening outside the hospital will be discussed in the face-to-face session. The following slide show various methods for labor induction, mostly mechanical and pharmacological. Historical or natural methods are listed, yet not evidence-based. For each method, the student should know its value, indication, whether it's used for labor induction, labor augmentation, or cervical ripening, its effectiveness and safety, and how it is used. That's to say, clinical protocol. The use of balloon catheters and laminaria may affect cervical softening, effacement, and dilatation with fewer or no systemic effects. The probable mechanism of action is local, either local dilatation or local release of prostaglandin. Balloon methods have the advantage of cost effectiveness and presumed safety in the presence of a uterine scar. Mechanical methods are not likely to be effective in inducing labor on their own and often require oxytocins for labor augmentation. Sweeping of the membranes may promote the onset of labor by increasing local production of prostaglandin. Discomfort during vaginal examination and other adverse effects, bleeding or irregular contractions, were more frequent in women who had the procedure performed. ARM, or artificial rupture of membranes, or amniotomy, is one of the commonest procedures performed in obstetrics. It's often used in conjunction with oxytocin for labor induction or labor augmentation. After amniotomy, the amount, color, and consistency of liquor is noted, which help assessment of fetal well-being. Care must be taken in cases of high presenting part due to an increased risk of cord prolapse, whereby a controlled ARM should be done. The potential risks related to mechanical method is listed in the following slides. Pharmacological methods are mainly subclassified into either prostaglandins or oxytocin. For prostaglandins, either dinoprostone prostaglandin E2 or misoprostol prostaglandin E1 may be used. Prostaglandin F2 alpha is currently not available. Different clinical forms are available with different routes is also used. The optimal dosing and the available trade names for different prostaglandins used are shown in the following slides. One form of prostaglandin E1 misoprostol and 3 forms of prostaglandin E2 dinoprostone are available commercially. Prostaglandin E1 analog misoprostol is a synthetic prostaglandin which is marked as an anti-ulcer agent under the trade name Cytotec. It may be used either orally, sublingually, rectally, yet more effective vaginally. 25 microgram vaginal tablets is also available. The dose frequency of use is related to the route used and the clinical indication and women characteristic. Note that the FDA classifies Cytotec as a pregnancy category X. 3 forms of prostaglandin E2 dinoprostone are available commercially: vaginal tablets, vaginal gel, and vaginal mesh. The trade names and dosing is given in the following table. The major risk of the above preparations is uterine hyperstimulation. The woman and the fetus must be monitored for contractions, fetal well-being, and changes in the cervical Bishop score. A discussion of the use of prostaglandin as a pre-labor induction ripening method will be presented during face-to-face session, during which the students are encouraged to read and prepare from suggested text a clinical protocol. Intravenous oxytocin has been widely used since the 50s for induction of labor. It has a half-life of 5 to 12 minutes, a time to steady plasma concentrations of 40 minutes, and a steady state uterine response of 30 minutes or longer. It is only used by intravenous infusion, mostly by an intravenous pump. The ideal dosing regimen of oxytocin is not known. However, it has been found that increasing the dose no more frequently than every 30 minutes resulted in fewer episodes of excessive uterine activity, a higher rate of spontaneous vaginal delivery, a lower rate of postpartum maternal infection and postpartum hemorrhage, and a trend toward a lower rate of cesarean delivery. Two main protocols are used, either low or high dosing protocol for labor induction or labor augmentation. The starting and incremental increase is shown in the following table. A discussion on the use of oxytocin as labor induction or labor augmentation method will be presented during the face-to-face session, during which the students are encouraged to read and prepare from the suggested text a clinical protocol for oxytocin use as a labor induction or labor augmentation. Suggested frame for an algorithm or a protocol for labor induction or labor augmentation or pre-induction cervical ripening is presented in the following table. During the face-to-face session, together with the students, such protocols will be discussed. Grand multipara and scarred uterus represent a relative contraindication or a caution for labor induction. During the face-to-face session, how to choose a method of labor induction will be discussed. For this clinical case, the student is advised to prepare for discussion in the face-to-face session. It is a 30-year-old female, para 2002, with two living healthy female and a male, 5 and 2 years old, after a spontaneous uneventful vaginal delivery. She is pregnant 40 weeks plus 5 days, seen at the ER with a decreased fetal movement of 10 hours duration. She has irrelevant past and family history with no history of vaginal discharge or vaginal bleeding. Her vital signs were normal. Abdominal examination reveals a single intrauterine pregnancy. Cephalic, fetal heart sounds regular, 140 per minute, non-engaged floating head, 4 to 5 above the symphysis pubis with no uterine contractions. Her pelvic examination revealed cervix soft, posterior, 1 cm dilated, 3 cm in length, membranes are intact, head is not well applied on the cervix, and pelvic capacity is adequate. What is the expected management for the resident on duty and what's the rationale? Question 2. Is there any alternative management and what is the rationale? Hope the presentation was clear and helpful. The student is advised to read the recommended texts and to see the YouTube links and be prepared with questions and discussion in the next face-to-face session. Thank you for your time.